Hello, good morning everyone. Today I'm going to present on radial tunnel syndrome. Radial tunnel syndrome is basically a compressive neuropathy of the posterior interosseous nerve at the proximal forearm or a radial tunnel. So epidemiologically, the incidence is about 3 in 10,000 populations. Affects more in male than in female, and also individual that is vulnerable to RTS is those performing repetitive manual tasks involving forearm pronation and also supination, and also athletes involved in racket sports such as squash, tennis, and also badminton. So anatomically, radial tunnel is around 5 cm in length, and it extends from the radiocapitellar joint until the proximal edge of the supinator muscle. It's bounded laterally by the extensor carpi radialis brevis muscle, extensor carpi radialis longus, and also brachioradialis muscle, bounded medially by the biceps tendon and also brachialis muscle, and the floor is the capsule of the radiocapitellar joint. While the posterior interosseous nerve actually is a continuity of the radial nerve and is passed through the spinator muscle. So it runs in a plane in between the deep and also superficial extensor compartment of the forearm. So it terminates in the wrist joint and by supplying the sensory branch to the dorsal joint capsule. PIN, posterior interosseous nerve, supplies the motor innervation of the superficial extensor of the forearm, which is the extensor digiti minimi, extensor digitorum, and also extensor carpi ulnaris, and also it provides motor innervation to the deep extensors of the forearm, which are the abductor pollicis longus, extensor pollicis brevis, and also extensor pollicis longus. The etiology of the radial tunnel syndrome is actually there's a compression of the posterior interosseous nerve at the one of these 4 common sites, which involve the fibrous band anterior to the radiocapitellar joint, at the radial recurrent vessel, or we call it as leash of Henry, at the medial edge of the extensor carpi radialis brevis, and also the tendinous edge of the supinator muscle. The usual complaints for the patients coming with radial tunnel syndrome is mostly they will complain of the pain at the dorsal-radial part of the proximal forearm, and through physical examination actually we can elicit a localized tenderness about 3 to 5 cm distal to the lateral epicondyle, which make it different from the lateral epicondylitis. We can also perform several provocative tests, which involve resisted long toe, resisted long finger extension, and also resisted supination in extended elbow and also extended wrist, and also passive pronation of the forearm with wrist flexion. So with all these maneuvers, patients usually complain of pain at the radial tunnel as well as weakness because of the pain. As for sensory wise, actually there's no cutaneous sensory manifestation in radial tunnel syndrome, but if there is changes present, especially at the first dorsal web space, we should consider a more proximal pathology, for example a radial nerve involvement. For the diagnosis of radial tunnel syndrome, usually we go by clinical, by thorough history and also detailed physical examination. And another approach is we can perform a diagnostic injection with local anesthetic, where we inject a local anesthetic into the radial tunnel. So patient usually complain of relief of symptoms, which actually provide both diagnostic and also therapeutic benefits as well. Imaging wise, MRI is actually not indicated unless we need to assess the muscle innervated by the posterior interosseous nerve. We need to assess any site of compression, And also we need to rule out any cause of the compression of the PIN lah. For example, tumor, but it's very rare. And the differential diagnosis for the radial tunnel syndrome, first is of course lateral epicondylitis, but the site of the pain is a bit different. But lateral epicondylitis actually coexists with radial tunnel syndrome in 5% of the cases. And another differential diagnosis is brachial plexus injury in a level of C5 or C6 lah. So finally, and we go for the treatment approach. Basically we will go for non-operative approach, recommended for about 1 year before we finally decide whether the patient should go into operative approach or not. So non-operative approach usually involve in the lifestyle modification, using of NSAIDs, use of temporary spleen, and also steroid injection. So activity modification wise, actually we can advise the patient not to have a prolonged arm pronation with elbow extension, also wrist flexion. We can offer NSAIDs for those still having persistent pain. Temporary splinting, we can refer to occupational therapy for temporary splinting, in which they can provide a splint to prevent wrist flexion during sleeping at night. And also we can also refer to physiotherapies for some exercise, stretching, and also stretching exercise to relieve the symptoms. Usually as recommended by American Academy of Orthopedic Surgeon, they will try this approach, the exercise approach, for about 6 to 12 weeks. So this physiotherapy usually involves wrist extension stretching, wrist flexion stretching, wrist supination stretching exercise, and also radial nerve glide. So finally, when all these approaches fail to provide relief of symptom for the patient, we can refer the patient to hand surgeon for a radial tunnel release. Okay, that's all. Thank you.